All right. And so we're going to get right into it. We're going to jump right in the deep end and start looking at coding for 2025 and some update and recommendations. We're thrilled to bring back Jan Blanchard, who's been our voice for coding over these last couple of years. And she's going to start the update. She'll also be available to break afterwards. So Jan, bring it on.
Thank you. Well, thank you. Thank you.
You can click here or you can click here.
Okay. Thank you so much.
Thank you.
Thank you, Dr. Weissman. And thank you all. I could not agree more with the sentiment that it is delightful to be in space with you all. Cultivating that joy, as you'll hear later today, is not something that happens automatically. So being able to share energy with you all and be back in space with you is something I hope never to take for granted. So thank you for being here. Thank you for making the effort. Early risers, early joiners. I know folks will filter in, and I'm looking at the people who are up front and paying attention. By way of introduction, I am Jan Blanchard. There are familiar faces here and a whole lot of you that I don't know that I've met before. And if I pretend I have, it'll be because I probably have, and I am embarrassed that I don't remember you. My memory is not getting any better as the years go on, which is why I rely so heavily on these slides to tell you the really detailed information that I've been asked to share. I am with Physicians Computer Company. We are a pediatric-focused EHR up in Winooski, Vermont. And I have been medicine adjacent for over 30 years. I don't feel old enough to be able to say that with honesty, and it's true. So I've been in exam rooms, I've been in billing offices, I've been worked in, not just been in, I'm sure we've all been in all of those places, but I worked in all those capacities, and most recently with PCC it was 22 years in August, and I am a subject matter expert in coding. So our pediatric specificity is what I bring to this conversation and discussion and presentation for you. Coding, generally, I'm really excited to be talking about this first thing in the morning because most people will fall asleep if I immediately follow lunch. I've seen it happen. I've almost fallen asleep in my coding presentations run that's immediately after lunch. These can be really dry. So what I hope to do is to give you these slides for the really dry references and add some context along the way and help you understand the changes that have taken place in ICD and CPT for 2025 and give you some tips and tricks and hopefully add to your understanding of the code sets and their uses. Wrong button. Good start. So here we are, all of that. This is common sense. This is just take this information and apply it to your context. Context is everything. So don't take something like this and say, blanket. This code applies in all of these cases. It's simply not that way. Be sure to apply all these concepts in the context of the care that you deliver, and importantly, in the documentation that you capture. More about that soon. What we're going to go over today is changes specific to 2025 additions, changes, deletions to the ICD-10 and the CPT code set. So that's I can probably put this down. That is the CPT and ICD respectively are the procedure code sets and the diagnosis code sets. Their purposes are different and their approaches and their value can be very similar. And what I mean by that, the value that they share is in translating the work that you do into a language that insurance carriers will pretend they don't understand. And when you master this, when you have insight into this, you can sort of stay ahead of their game. And you can be prepared to argue and win some of the debates you get into with payers when they're supposed to be paying you according to your contract. When they fall outside that, your understanding of this stuff is going to make it easier for you to spot that, for your billers to spot that. What I'm going to help you understand is what has changed and hopefully impress upon you the ways that you can document to these changes in a way that lets you out of the billing cycle if you don't want to be in it. So you as clinicians have the clinical experience, you document the clinical experience, and then ideally you deliver it unto someone in your office who can argue with the payers so you can get back in the exam room and keep seeing kids. So that is what we're going to cover. That's the aim. One bit of information that I really like, or a bit of clarity that I like to add early on, is the difference between coding and billing. When we speak of coding, we're talking all about the theory. We're taking the list, the massive manuals of codes, and we're applying them to your real life experience. When we talk about billing, in contrast, we're actually describing the relationship that you have to the billers. To the payers, and the ways that they misbehave and misinterpret what they should be doing in your life. The billing answers are ones that are much more difficult. It's easy to conflate those two things. And billing answers are something that it's much more difficult for me to offer, simply because that is so dependent on the contracts that you have and the payers that you deal with. They will very frequently require that you code improperly as a way for them to gather data about your panel, a way for them to satisfy their own reporting and data needs. There's a whole host of reasons that they'll ask you to use the codes badly. And in general, I'm going to ask you, be sure that you get those misuse requirements from them in writing. I've seen far too many times a biller crying in their hands because they can't argue a denial that was issued by a payer who said, well, send in this HCPCS code on every one of your well visits, and we'll count that toward your utilization, and we'll give you utilization bonuses, only to have none of those bonuses come to fruition, have none of those checks show up like they should have, only to say, well, whoever told you that? And saying that it was Cindy when I called the 800 number back in December, that's not going to hold up. Get that in writing. Make sure that you have something defensible, something in their parlance, on their letterhead, electronic letterhead, to defend the reasons that you are misusing the codes the way that they tell you to. So first, we're going to go through the ICD changes. Why should you care about whether the payers know exactly the nitty-gritty, fine little details of why you're treating your patients? And the reason these codes and these concepts are important is because this is the language that they're going to use to determine whether you should be paid. So most people understand easily that the CPT codes have a monetary value, and they tell what happened, and we get paid for what happened. We don't get paid for why it happened. Well, that's not entirely true. There are combinations of CPTs and ICDs that some payers are writing edits into to automatically reject. For argument's sake, they'll say 99214. Diaper rash can't be a 99214. Meanwhile, the family had communication issues and social determinants that you spent 40 minutes talking with them about to get that diaper rash treated properly and to be sure that it didn't exacerbate and turn into something. So don't fall into the trap of not knowing how to express exactly why you did what you did. This is equally important to CPTs. What I use to create this presentation is information that is freely available to you. You wouldn't have to spend anything other than labor time and the cost of labor to do an analysis like this. These materials are all free. Unlike CPT, the ICD resources, you could give these links to your biller and they would have everything that I had to work from. There's a really awesome, every year, there is a tabular addendum that is what I base all of these presentations on. It summarizes the changes. So in geeky computer terms, like us EHR folk like to use, it's a change log. So it tells you just about the changes. You can ignore almost everything else about the 25 manual if all you care about is the changes. You can look at that tabular addenda. The guidelines also are important to understand and know. There are no material changes to outpatient peds in the 2025 ICD guidelines that I could see, and it's good to understand those concepts. There are concepts in there that your billers will want to know about, and things like sequencing. There are rules about what order combinations of ICDs can be in, that sort of thing. There are also some overarching concepts that are going to be important to you that I'll briefly cover as well. Those are all defined in those guidelines. Excuse me. One of those things, one of the guidelines, an important concept for you to understand is when codes should not be used together. And there are two types of what we call excludes relationships. I won't belabor this, but it's good information, it's good awareness. When two codes have a relationship defined in the manual as excludes one, that means that the two conditions cannot occur together. So this example is a good one to illustrate it. If you were to diagnose excessive crying in an infant and you reported R68.11, it would be contradictory to then also report R45.83 because that is excessive crying in someone of a completely different age. So you would not ever, so an excludes one is something you would never report together. And those are going to be edits that your payers will exclude too. So don't report those together. It would be illogical and accidents happen. This is what they mean if they deny based on excludes one. Yes. Yeah, so the question was, do you mean don't use those both in the same encounter? Or do you mean that those can never be used for the same patient over time? And it would be in the same encounter. You wouldn't use them for a point in time. This one being temporal, you wouldn't use those at the same point in time. Good question. I don't know what the preference is for questions. Do we want throughout or wait till Q&A? As we go? Okay, we'll see how it goes. If we get really late, I may cut questions off just to try and keep on schedule. Excludes two. How do I go back? There we go. So excludes two is a little bit more possible. Oh, here I'm talking about questions and there's one in front of me.
Are there any lists that we can have? Like this one was obvious, but are there other things that may not be that obvious that we need to be careful about?
Ooh.
Or where can I find something like that? I didn't know about this.
Yeah. Oh, great question. So I don't know of a list, and I'm the type of person that is now going to go home and hope that I find time to create it for you. So the place that I find it is in the context of the codes themselves. In the ICD manual, it's right there in the context of the tabular side. You won't find it in the index, but in the tabular. But compiling a list of excluded codes, excluded pairs is a delightful idea that I will take home and try to find time for. I don't know of one. Actually, that's the first research I'll do is to see if it exists. Thank you for the question. So exclude two is a little bit more possible. The excludes two are included because it's unlikely that a patient would have both conditions, that you would use both codes in a single encounter for a single patient, but not impossible. So it's more for the purpose of saying, I see the code you're going for. Did you consider that this code also exists? It wants to be sure that you're using that you're following that cardinal rule of coding. Use the most descriptive, most accurate code that is applicable. So be as specific as possible. So this just says, keep looking. If this other code matches, make sure you're making the best possible choice. So getting right into it, I do these analyses chapter by chapter. So that's the way I organize this presentation. And each chapter in ICD corresponds to a body system. That's the way that it's organized. It was intended to be head to toe. And when it first came out when ICD-10, this version came out in 2015, it was head to toe, and then additions were made in it. And so that's not entirely true all of the time, but that's the general organization of it. The first edition that I wanted to tell you about is a handful of eating disorder and weight management related codes. So in this chapter 4 endocrine chapter, endocrine, nutrition, metabolic diseases, overweight and obesity has a whole host of new codes. And the classes that you note here, that you'll see here, related to, I'm not checking my messages, I swear I have notes in here that I want to be sure that I cover. The classes that you see referenced in this description has to do with something that is defined in the clinical practice guideline, the most recent update for E&M for children and adolescents with obesity. So these were defined in Pediatrics, and the classes relate to, for obesity in particular, the classes relate to BMI. So the BMI expansion that happened where there are now percentiles 122 less than 140, and then that additional range of 140 greater than or equal to 140, that's what these apply to. So when you're diagnosing this, use the class that corresponds to the patient's BMI on that encounter. Similarly, anorexia nervosa includes a whole host of new codes the greater specificity has been added. And as I said, be sure that you're using the most specific code possible. What you've got here is some descriptors, again, that have colloquial meanings and have clinical meanings. And in this case, the mild, moderate, and severe have to do with the way that they, this is also BMI. So when it's anorexia nervosa, the BMI range is noted right in the codes. So 17 plus, not in the codes, I'm sorry, in the clinical guidelines. So 17 plus, 16 to 16.99, 15 to 15.99, and then less than 15 respectively. Continuing in this vein, binge eating purge type anorexia nervosa also has been expanded, and there is greater specificity available for your use and indication. These categories also depend on BMI. And finally, bulimia nervosa also has this breakout, but these categories are based upon the number of binge episodes per week. So I say all of this not to bore you, and if it's good for awareness, but another goal of these talks is to be sure that you understand this in a way that's going to help you create documentation that lets you conduct the encounter and then take yourself out of the billing process. When you are specific in your documentation in a way that supports these changes, or not supports, but rather matches the code selection, if you're using language that your billers can then use to defend your note, you can go back to the exam room and leave the rest to them. You don't have to get into a clinical argument with your payers. You've got it on paper. Even, and as importantly, you've got it captured at the time of the encounter, which if you know if you're familiar with the billing cycle, it'll take the payers will take their sweet time replying, and they'll take their sweet time answering when you challenge something. By the time you get to a point where you distill that it is a clinical disagreement that they have or a clinical question that they have, your memory may or may not be considered reliable at the time that you end up having the argument about whether or not the patient's experience was matched to the ICD. So write this down at the time of the encounter, and it's kind of a set it and forget it approach to it. You are empowering your billers to do that kind of arguing for you and not have to get you back into it to defend it. Binge eating here, this is again the number, you know what, I think I misspoke. Yes, the language, I'm being so particular about language and I misspoke. In the binge eating disorder codes themselves, the terminology is the mild, moderate, and severe categories are based on what is called inappropriate compensatory behavior episodes. So it's not strictly binge eating episodes. It is, that is the language, and I'm hoping that means something to you clinically, because it is not something that I can interpret for you. I just want to give you the words that match what the ICDs are intending to convey. It is with this, now I'm getting out of order here. So let me make sure I'm getting this right. So the bulimia nervosa is the inappropriate compensatory behavior episodes, and the binge eating is the number of binge eating episodes within a given week. That's what these categories are based upon. In Chapter 5, continuing, other behavioral and emotional disorders with onset usually occurring in childhood and adolescence. While there was no change to the other feeding disorders, the F98.2, there are some additions to the guidance that goes along with using that code. So if you're using F98.2, be sure that you understand these synonyms and additions here. There is an excludes thanks to the addition of some rumination disorder codes in another chapter. So again, that excludes one. If you're using F50.84, if the patient is of adult age, be sure that you understand that you're not going to be using that childhood code. You're more likely to be using the childhood code, but understand that excludes relationship to the adult codes here. PICA of infancy and childhood did not undergo a change itself, but Again, the pica in adults was added as an excludes. Some of these I include for the purpose of billers that are really on top of it, and they look at that change log and they say, wait a second, what changed about this? I want to be sure that the meaning of the code itself is clear. That didn't change. It's simply the combinations or relationships to other codes that did. So it's not a material change if you're using it. Just be sure that that you understand the nature of that change. Chapter 6, the only thing that I saw that might possibly be tangentially related is a new code for developmental and epileptic encephalopathy, brand new code for your use, as well as serotonin syndrome. So serotonin toxicity, and this also includes another coding concept that's worth mentioning is code first. When you come across a code that says code first in it, that is a hint toward one of the concepts I alluded to in the guidelines description, where the order that you put these codes in matters. That there are some that simply are take precedence. There are conditions that take precedence over others, and the reporting guidelines will tell you what that particular order is. This is one of those hints. Oh, so I should be more clear. The code first is if serotonin toxicity is due to a drug or toxin as opposed to another source, that's when code first should be employed. You should be looking for the toxin or the drug. There would be a code more specific to the drug that's causing it. Getting into chapter 10, there is, again, I include these for your reference. May not be something that you treat often, and there is a whole new set of codes for nasal valve collapse, if that's a thing for your practice. So that is the ICD changes. So the things that I thought were materially important to you for diagnoses. And again, I overlooked specifying or calling that the effective date for these was October 1st. So if any of your dealings with insurance carriers has to do either rejections or denials based on ICD, what I shared with you went into effect October 1st. So any services on or after then are beholden to these changes and additions. There, again, I think I mentioned already, there were no changes to the guidelines that I saw, the ICD guidelines. So getting into, yes, there's a question. Oh, good question. So the question was, when you see an ICD that, thank you for the microphone. Yeah, if folks have questions, I know it would be a favor to us all if you, and it'll save a bunch of time through the day if you head up to a microphone. So the question was, if you use a code that you discover has a description of unspecified, or if you're considering a code and there's one option for unspecified, that is a great question. I'm glad that you asked, because the concepts of other and unspecified, those are two words that you're going to see often in the ICD descriptors, and they have very specific meanings in this context. Other means that you look through all the codes, and the variation of that code that you're looking for is clear to you. You understand it, it's documented, and it has a clear origin or a clear cause, but there is no code that matches it exactly. You would use the other version. Using the unspecified version is reserved for when either your experience in the exam room couldn't possibly tell you, or the document that you're coding. So when I'm coding from a document and the document doesn't say, I can use unspecified. So I think the nature of your question was, should we ever even bother to use unspecified? And you should, yeah, in that case. Specifically, when ICD was implemented, I want to say the otitis media, and it may persist. The otitis media codes have options for which organism it is they're infected by. Primary care peds, you're not going to test their ears to discover which organism it is necessarily. So unspecified is perfectly appropriate in a case like that. Thanks for the question. Yes.
Good morning. Thank you for being here again. I have a question about type 1 diabetes. There's 2 new codes for staging type 1 diabetes. Are you familiar with those codes?
I am not.
So there's a code called E10.A1 for stage 1, that's when you have insulitis, means your autoantibodies are positive, but you're euglycemic. And then there's a new code called E10.A2, that's when your autoantibodies are positive and you're dysglycemic, but you're not hyperglycemic and you don't need insulin replacement yet. Those came about in October.
Okay, thank you so much.
Thank you.
I appreciate, yeah, I'll make that addition. I appreciate the addition. Any other diagnosis codes before we move into the CPT side of the thing? All right. So E&M, there is a handful of new E&M codes that are going to go into effect on January 1st that you should know about. They include, but are not limited to, a synchronous audio video E&M new patient requiring a medically appropriate history and/or exam, and the level selection is based upon medical decision-making or time. So similar to existing E&M leveling approach, the constraints for choosing your levels, and these are specific to audio and video. So my prediction for this is that these replace the 95 modifier in some cases, and the office E&M codes will no longer be as specific. So that requirement that you code to the greatest level of specificity, this is going to replace telemedicine codes using the typical E&M service codes for telemedicine. All right, so 98,000, straightforward, 98,001, low medical decision-making. And there's a concept in CPT that is widespread. You'll see some services mention one series of codes for MDs and another series of codes for other qualified healthcare professionals. Because E&M is special, there are particular licensure levels that are eligible to use E&M codes. There's a subset of those. So the reason that you don't see that indicated here is because it's understood by CPT concepts that only certain clinician types can render E&M services. That can be, so it's tied to licensure. And so this is a new patient series for synchronous audio video. This is an established patient for synchronous audio video. And again, these are based on time. Some of these are based on time. You have that same choice for choosing these levels as you do for face-to-face, in-person E&Ms. You can either do that based on medical decision-making level or on time. And again, be sure you document that time. A few months ago, PCC crested the 1,000 records audited milestone. And I can say with some certainty after that billing based on time is an underused tool. The amount of time that I hear folks talk about spending and the amount of times that the amount of times I see you record the time that you're spending, there's a great disparity there in my experience. The tip that I can give you that I think is useful in that case is when you go into an exam room, note the time that you walked in. You don't have to capture time for every visit. It's not appropriate to bill on time for every visit. But what you never know when you walk in there is what they're going to tell you that they didn't tell your appointment scheduler. So how many times you go in for an eczema and you walk out having had a conversation about sexual assault or something similar, something time consuming, something where one of those visits where you put the rest, you kind of let your manager know, I'm going to be in here for a bit, and you pause your day and deal with that. That gives you a really accurate assessment of how long you've been in that exam room. So if you just capture the start time of every visit, you're poised to, in a really detailed way, capture the time that you spent with each given patient. And there are now also codes for synchronous audio only E&Ms. So these are phone calls. I'm extrapolating this to be if you try to do audio video and the video fails and you have to convert that to an audio only. I don't see a reason that this wouldn't apply to that. I had that question from an audience member recently, and that got me thinking about it. So managing this is also inclusive of all the time that you spend managing a patient. And, excuse me, again, medical decision-making or time. One of the things, let me make sure about this. There's a series of these new codes that also are excluded from use when you're billing things like transitional care management, chronic care management, the monthly chronic care management codes. There are some exclusions across these new, and it is not this set. So I will bring it to your attention when we get to this set. This is the one. So this is synchronous only audio E&M for an established patient. So let me be clear about the difference that I just alluded to. New patients, you would bill these. You don't know the patient yet. If this is the way that you are introduced to the patient, this is your first experience with the patient, is an audio only visit, you can bill that. This becomes possible. And it is only with established patients. So the similar set of codes for established patients for synchronous audio only has some exclusions. You can't bill those in the same month that you bill a transitional care management code or the chronic care or care plan oversight codes. So be sure that you understand those exclusions. One or the other is going to be denied, and you want to be sure about which one is, I don't want to say more lucrative, and that's a reality. Be sure that you understand the payment implications from your contracts. Look at these codes and look at what your payers are paying, the rates, and compare the rates across them as a tiebreaker. Whatever is the most descriptive and most accurate should be reported, and when they're equally applicable, you'll have more information to make that choice. There is also a brief communication technology-based service code that has been added this year. And the way that what this boils down to is if a clinician is in touch with a patient to discover whether they should come in for a more extensive evaluation, that's a use for this new code. So it's a check-in. It has to be patient initiated. And this is only 5 to 10 minutes of medical discussion. If there's less than 5 minutes of discussion experienced, there's not a code for that, and it's recommended that not be reported. But if you're in the 5 to 10 minute range of talking with the patient to decide whether they should come in, that's a typical use. That will be a typical use of this code beginning in January. This is beholden to the same rules as some of the other telehealth codes, wherein it's only reportable if it doesn't result in them coming in. So that's what the last few phrases in this slide indicate, is if you have the next available, if they take your next available appointment as a result of this conversation, you won't forfeit any of that work, but you will incorporate it into the ultimate level that you choose for the visit that ends up transpiring. So don't throw away those notes. Use them to increase the complexity of the document for the visit that results. There was a question here.
And introduce yourself.
Елена Балакирский, Paxil Pediatrics. Seems like we're gonna be able to do billing for phone calls?
Yes, the synchronous audio only. When you document time, they are time-based codes.
So, everybody, as my understanding here, answering the phone call after the like night phone calls, and that's what we're billing for? What those codes?
Yeah, if you've got these are appropriate history or exam, at least 10 minutes of medical discussion. So unless you hit the 10-minute mark, they're not billable.
Mhm.
And if you're documenting a history and exam, if that's what's happening in synchronous audio only, yes.
Synchronous audio. So we need to connect with the patient.
Yeah, it's live interpersonal audio.
Live interpersonal with video.
No,
or
audio
audio.
only. Audio only.
How you do exam? By the audio?
Exactly. So the question is, how do you do exam? I'm uncertain, but if there is a way that you are, if it's something that you don't have to lay hands on, if it's discussion based and it doesn't require physical, if that can be counted as an exam, if it's not a physical problem.
Okay.
Is that helpful? And there's a question here.
We can
Oh.
discuss some of this at the end of the session. As many of you are aware, just because a new code gets created and put out there doesn't necessarily mean it immediately percolates into our lexicon as a reimbursable code, but you got to start someplace. So
Yeah.
take a chance.
Yeah, I should say there's no requirement for you to report that code. No one's none of your payers are gonna chase you to ask you to. But if you do, these are the constraints of it and these are the definitions.
I think where we were just discussing it, where it's confusing, Christine Saba from Saba Pediatrics. Synchronous audio, is that my telephone? Can I
Yes.
use? Yeah, that's
Right.
it. We're
Yeah.
good. Now we all.
Seems too good to be true, right? Yeah, so documenting time will be really important in this one, but no more important than any other. So, and that's one of the nice things about cell phones is the cell phone will tell you how long you were on the phone with them. If you use your call log, you've got a duration. There's a duration in your call log. All right. So, oh, that's this one. Continuing again in the same vein as don't worry about some of the conceptual changes to ICDs. There's a corollary in the CPT side of things. And when I say conceptual, like the add-ons and the synonyms, the code itself didn't change, just the synonyms. These are similar. If you can believe it, there was ink spent changing the phrase about around assessment and management services for describing something not as a qualified non-physician healthcare professional, but as a non-physician qualified healthcare professional. So that is meaningful. If you see the acronym change, you may see QHCP. If you see the acronym change, that's not material either. It is simply a change to that phrasing. Education for patient self-management. The change to this has to do with that change itself. So the non-qualified healthcare professional, that's the only change to this. These are not new codes. I will fix that slide at the top. I typically reserve that word new for codes that have been added in this code year. Please accept my apologies for the typo error. This is not a new set of codes. It simply capitalizes or pulls through that non-physician qualified healthcare provider change. I do like to include the codes that have been removed. So as you can see from the E&M, not quite overhaul, but the E&M additions and changes, there are some codes that will no longer be honored after 12/31/24. So if those are in your billing system, I include these here for your awareness. Don't waste your time reporting them after that date for encounters beginning with January 1st. You will give your billers a headache and waste your time. There are new labs available for you to report. So if you are performing the HPV, the HPV test in office that is described by these, then these are new codes for your use. The HPV with the high risk types and high risk pooled result, the strep pneumonia antibody immunoassay, and the H. pylori amplified probe technique testing. Be really careful billing labs. When you're doing in-house labs, be certain that you're picking through those descriptors and that what you're performing in your office matches all of the things that are described in the code. There's no shortage of folks that are reporting things that their equipment cannot do. So the amplified probe, I know those machines were rolled out to a whole lot of offices in the last few years. Be clear with your vendors about which codes match the technology that they sell you. They are a good source. If you haven't used them before, the vendor that sells you the machine often has a very vested interest in you getting paid for that machine. That's for getting paid for using the machine. So some of them are leased. They want to make sure that this is lucrative for you and that you continue signing that lease. So that is another resource that some folks don't realize is a coding resource. Continuing with labs, another HPV high-risk type. I don't think that's different to the other. No, it is different to the other. See, this is the nitty-gritty little details. So please be sure to make sure that it's the types that are different across those two codes. Be sure that you are billing only for the types that you're testing for, and billing for all the types you're testing for. Vaccines. whole lot of changes in the vaccine realm, new codes for some of the new supply, the pneumococcal 21, the meningococcal pentavalent. And again, similar to labs, the details matter. Be sure that the code that you're reporting doesn't include a detail that is a mismatch to what's being done in your office, that it's not a different technology, not a different analysis type, not a different target, you know, the organisms and types that are targeted in each of these codes and in the tests. Be sure that those match. It's worth your while to get those right the first time. Dealing with paying those back when the payers discover a mismatch somehow, if they're looking for proof, or if they do an audit and see a lab result that doesn't match the, there's a word that's escaping me, doesn't match the approach that's used by either the kits that you're using, the supplies that are in use in your office, whether they are the CLIA waived or the CLIA certified version of a test matters. And these are the details where those things are determined. Vaccine administration. There is a whole lot of change here in that the administration codes have been added for the RSV vaccine. There is now a version of the vaccine administration, the RSV administration with counseling and without counseling. And that is the distinction between these two codes here, 96380. So again, this is a documentation tip as much as anything. Be sure that when you're giving RSV, you're documenting that you took Q&A and that you addressed concerns and that sort of thing. That's going to support billing the version that includes payment for counseling. Flu vaccines. So my strong preference is when new supplies are approved and are in use and delivered to your office and you're administering them and they have a new code associated with those supplies. That is by far my preference. There's a new code for the new supply. That is true in these first three codes that describes these three flu codes. What changed is that 90661 represents no longer represents the preservative-free version. So understanding clearly which version you give to each patient in order to report it properly is important. So be sure that you are documenting or in some way have captured the preservative and antibiotic status of the supplies that you're delivering. That's going to determine the choice of code that you use to report that supply. The removed vaccines, again, for the same purpose as before, be sure that you're not using the 90630 or the 90654. Those are expired, those will be expired codes. And the COVID vaccines in particular, the only previously used COVID vaccine product that will persist is the 91304. So be sure that that is what you'll use going forward. And there is one administration code now for all COVID vaccines as well, 90480. The preservative-free, again, a change, not my favorite. Do you sense the very stark before and after preference that I have? That gets muddied when these code descriptors change. So the 91304 will no longer represent preservative-free. Be sure that you're, again, noting which version of the supplies that you're delivering or administering. The new COVID vaccines, you've got the whole host of combinations based on the patient's age and the manufacturer, and that's these here. And again, that single admin code, 90480, immunization administration IM, severe acute respiratory syndrome, single dose. And these are the removed codes. Again, want to be sure we're adding value and giving you a definitive list of things that should no longer be billed. And I'm going slowly just because I see so many cameras open. More removed codes. And I believe the handouts will be available, so I'm going to move on. I'm running low on time. No shortage of changes. In the handouts also, I included this link because there is apparently a spreadsheet. I don't know if I told Chip this. There is a spreadsheet that is updated by AMA frequently that is available for your lab testing and vaccine codes. It brings all those together. I'm a lover of a spreadsheet. So if you've got folks that just want a handy reference of the currently available, effective, or in use lab testing and vaccine codes, AMA is making those available. You have to fill out a form. I don't know what they'll do with your information, but it's the AMA. They're going to get something from you. And that is all the content that I have. Did I leave? Do we have a minute for more questions? We do. Yes. Good morning. Oh, good question. So for the telehealth codes, do you have to use a modifier with those? That'll depend on the modifier. So I think that the 95 modifier would be redundant. It's described in the code itself, whereas before, if it was E&M, you had to say 95 to express that it's telehealth. But because of the telehealth descriptors right in the code, I don't think that'll be necessary. As always, your mileage may vary. If your payers are issuing memos about these new codes and how they want them reported, adhere to that. Keep that in hand so that your billers have something defensible if they turn around and say, we never said that. But again, that difference between coding and billing, getting paid is what keeps your lights on. So follow their rules, document it when they ask you to do something that seems wonky or seems out of coding norm, and collect those checks. I say that facetiously. They make you wrangle those checks. Any other questions? Thank you so much for your kind attention. It was really nice way to start the day with you all. Thank you. Oh, I'm so sorry.
One more. Yes, hi, I'm
morning.
from Dr. Gannison Pediatric Office. Do we use any modifiers for in-house labs, like CLIA-waived, QW, or the new lab test, strep and chlamydia and all that stuff?
So I think the question is, do CLIA-waived
Use.
labs require modifiers?
Yes.
They do, yeah. So that is a combination of the status of the lab in your office and the code that you're reporting. So there are some labs that have a CLIA waived status where it's understood that the lab doesn't require CLIA waiver. Your payers may still want you to use that QW. They really, really love modifiers. It's a very simple way for them to, it's yet another detail for them to pretend they don't understand and say, oh, you needed a QW, you got to put it on there. Or wait, you put a QW on there, we can't pay you. So it's hard to answer in a general way because it depends on what type of lab you have in your office and what the specific lab is. But I'm happy to research a few with you if you like.
Sure. And the next one, I'm sorry, do we use any place of service for telehealth, the new?
Oh, another great question.
Yes.
Yeah, so place of service for telehealth is another thing that I've seen payers manipulate to their what do they not manipulate to their gain? And it would be redundant possibly to some places of service unless it's saying that they're in your office and they're receiving telehealth from a remote specialist. That's one way that I could see, but they would be you might be billing. Oh, if they were in your office, you wouldn't be reporting telehealth. That'll depend on where they are when you conduct the telehealth. So I could see the place of service possibly mattering even for those synchronous audio. That could be a possibility if you know that the patient is, a strange example, but to illustrate the point, if they're at a specialist's office and they call you and you talk with the patient, that could be one of the places where I'd see the place of service mattering, but otherwise it would be assumed that you're remote and whether they're in their home or assumed to be in a place where they live, that definition of the place of service could come into play. And it may not be 11, the typical office place of service. It'll depend on the circumstances of the encounter.
If they are at home, it's going to be 11, right?
It wouldn't necessarily be if it's telehealth. The telehealth place of service that indicates that they're in their home would be more appropriate for coding purposes.
Thank you.
You're welcome. Time for more, or are we wrapping? I could do this all day. Thank you so much.